Okay, it's a good afternoon. It's a pleasure to be here another again. And I'm going to talk about the alignment, the first phase of the orthodontic treatment. This is about the efficiency in orthodontic, and we are talking now about the alignment. First of all, I would like to talk about a little bit about what is the objective of my clinic, of my the objective with my master students many years ago. The master was to introduce in the brain different concepts and different ideas about my orthodontic philosophy, to introduce a lot of things about biomechanics, about diagnosis, about a plan of treatment, about the different protocols for the treatment of the class 1, for the vertical patient, about a lot of things. But nowadays, the most important in our office, the main objective for my students is the clinical success. What is clinical success? Is to bring patient who bring another patient. For the reason it's very important in the marketing to adapt our wishes and the protocols of our office to the desires of the patient, to the clinical success. The clinical success is to change the face of the patient, change the smile of the patient, and change the occlusion of the patient. What is clinical success for the patient and for the parents? The clinical success is to be something like this. You can change the smile of the patient from this occlusion with a narrow palate to this development of the teeth. And this is the change of this smile is thanks to the growing of the alveolar bone. For example, this is a patient with a TMG problem. What is the patient? The patient is the desire of the patient is, or the patient refuse orthodontic treatment. The main problem of the patient is a pain close to the ear, and the main problem of the patient is a pain in this point. What is the idea? Is you have to analyze the TMG problem, the psychological problem, the central nervous system problem, or the occlusion problem. The most important question is about the relationship between the occlusion of the patient and the TMG problems. Maybe the problem is when we are talking about the TMG, we divide the TMG according with Rocabado in three parts. The first part is in relationship with the meniscus. The second part is in relationship with the muscle, the pterygoidea muscle, the inner masseter muscle, the temporary muscle. And the third part, in this case, very, very important, is in relationship with the retrodiscal area. When you have a occlusion like this with the upper incisor in a retro position, the main problem of this patient is the compression of this area, the problem of this area. For this reason, my hypothesis in this patient is maybe the retrodiscal pain, maybe the retrodiscal problem is due to the retroincisal position, the retroincisal position of the upper incisor. For this reason, I prefer to check the patient in centric relationship, and we decide to put in a splint, maybe to put in a splint. The ideal treatment is the orthodontic treatment. What is the problem of this patient? The patient refuses the conventional treatment with brackets and wires. The aligners is a little bit expensive for the patient, and the patient asks to me about the guarantees of the treatment because according with the patient, the situation of the upper incisor is okay. The patient look for a simple treatment. What is clinical success? Clinical success is the adaptation of our treatment to the size of the patient. For the reason, the first step is to use a removal appliance, a very simple removal appliance, a very simple removal and cheap appliance. Using a couple of screws in the right and in the left, you can see this wire, this is night-type wires to produce the protrusion of the upper incisor and to increase the adaptation of the appliance, the wires of the appliance to the teeth. I put a little bit of composite in the right and in the left for the patient to engage the wires in the lateral incisor. You can see the spectacular effect of the appliance, and now the patient is the patient is very happy because diminishing the pain at the level of the air, close to the air, so the level of the TMG, and now it's time to put brackets in the lower. We combine lowering brackets in the lower with class 2 elastics to move a little bit forward the mandible. Now I put a piece of white wire in the upper to align the teeth, okay, and finish the treatment with brackets with straight wire friction brackets in the upper and the lower, and you can see the excellent result of the patient. Now the patient is very happy without pain in the retrodistal area, with a very good occlusion and with a very good periodontal health. I think this is the idea. Successful. Imagine if you put a splint 24 hours a day. The patient refuses the orthodontic treatment. If you complicate the life and put splint, orthodontic surgery, a lot of things, this is against to the clinical success. For this reason, it's very, very important, and my objectives today with my students is the orthodontic knowledge, critical thinking is very important, evidence-based treatment or evidence-based orthodontic and clinical success. Most of the orthodontics believe that there is a deep crisis in our specialty, and we have to analyze briefly our professional weakness and threats. This is the crisis. The main problem of the crisis is in the future. The aligners with online shopping. Remember the case of the direct club smile. This is in connection with Invisalign. There are a lot of threats on the horizon. And many years ago, I bought the brackets and wires, and my training, my brain, my hands are my capital gain. And maybe I bought, I don't know, 100 euros, and the cost of my treatment, okay, my cost of my treatment is 10 times the price of the material. What is the tendency today? Today, the tendency is to open for a lifetime, or the idea is to use aligners and to send online aligners, and the idea is to eliminate first the orthodontist and eliminate second even the dentist, and to create different office of the company. For this reason, it's very important to understand this. Maybe today you are the best dentist in the world, maybe the best orthodontist in the world, but tomorrow you will wake up in a world that doesn't not exist. For this reason, it's very important and remember who moved my cheese. What is my aptitude for the future of my profession? What does the patient wants? Good service, comfortable appliances, fast treatment, few appointments, high quality, cheap, aesthetic appliance. What do my rivals offer, or what do I offer? And I think it's very important because we have a lot of problems in the future of our profession, like this. The millennials nowadays, the shopping of the millennials online is about 41%, and maybe in 3 or 6 years, the shopping online will be 75%. For this reason, if you decide for the market of 2010, I recommend to focus on what make you different. Change your office, change your philosophy of treatment, change your ideas for the successful in the future. It's very difficult to analyze this. What is my opinion about the future of our profession? My opinion is about in the future maybe we will have two types of office. Careers, the focus is in the careers, and the focus of the second type of office is the smile design. And the smile design, why? Because do you have this clinical case? Who understand the malocclusion? In this case, it's very difficult to treat this patient or too difficult is to diagnose this patient for the general GP or for the general doctor. What is the ideal treatment for this patient? It's very simple. The ideal treatment is this: the straightening of the molars and premolars, and to close the space and extract the premolars and the rest radicular, the roots of the molars. One question in the future: can the general practitioner, the dentist, without orthodontic knowledge, to do a good plan of treatment? In my opinion, only in my opinion, the answer is no, is not possible. More than 80% of the GPs, of the dentists, don't have enough orthodontic knowledge. For this reason, Houston, we have a problem. In the future, the patient bring to the clinic with the X-ray, CBCT, maybe if in 3D photos, a intraoral scanner, and this is a very big problem because in a lot of clinics we need the opinion of an expert or specialized in orthodontic. For the reason in the future, there will be two types of clinics. The first is the caries clinic, the GP and the different specialized around. In my opinion, what is the best clinic in the future is very simple: smile or facial and smile design clinic. The center is the orthodontist and the specialized is around the orthodontist. Remember the evolution of our profession with Roth, with MBT. In the 2000 was very, very important, the evidence-based orthodontic, the treatment with evidence-based orthodontic, the new wires, new supraelastic wires, the use of the mini screws, the digital orthodontic, and in the future, two things. The first is the diagnosis centers. The diagnosis centers for the complete treatment with aesthetic, with orthodontic, with implants, with the evaluation of the patient like home. And the next point is the memory shape polymers. What is memory shape polymers? Is the next step of the aligners. For this reason, we have to change the normal and orthodontic and craniofacial science with the limitation of the orthodontic records, the hard tissues paradigm, the soft tissues paradigm, the orthodontic tooth movement, the limitation of the dental expansion, the orthopedic during the growth, the edgeways, the functional appliance for a new orthodontic and craniofacial technological and concept. The new technologies about the aligners, about the CBCT, the new concept about the alveolar bone growth and new researches, and the new professional change like emotional change and neuromarketing change. For this reason, we change the traditional orthodontic for a new orthodontic. Excuse me. For the reason we need dental harmony, facial harmony, soft tissues balance, static occlusion, dynamic occlusion, TMG, periodontal health, long-term stability, the efficiency, the upper airway problems, very important, profitability of our office, patient satisfaction. And the next, and the center of our office is the smile. The smile according with the new parameters. For this reason, we have to focus in the new orthodontic, in the new orthodontic office, in the new orthodontic office, and in the center in the smile is the ortho smile design office. I need to work together with the pediatric dentistry, the prosthodontists, with oral surgery, with the cosmetic dentistry, dental public health service, and the objective is the same: dental aesthetic, digital diagnosis and 3D, soft tissues balance, eyewear, craniofacial growth. And very, very important, we are the orchestra director. For this reason, it's very important to understand about our biomechanics. Remember that the most important in relationship with the friction is the binding and the notching. The notching is the deformation, the out of shape of the new wires, especially the beta 3 titanium wires, the gunmetal, and the new titanium niobium wires. The notching and the binding is very important because to limit the length of the treatment, increase the length of the treatment, because it's not possible, for example, in the self-ligating brackets to introduce at the start of the treatment thick, super elastic wires. For this reason, this very important is the application of pairs of forces at the end of the slot of the conventional bracket or conventional slot, in conventional bracket or in self-ligating bracket. For this reason, the binding and the notching, the attempt to introduce rectangular superelastic wires in these brackets produce a problem at the end of the treatment and produce a huge problem at the start of the treatment. We need to put, for example, in the self-ligating brackets, we need to put 2 or 3 round wires to get to 90 by 25 night eye. The initial friction, remember, this is in relationship with the binding effect, with the notching effect, and the cold welding. And the sliding classical friction, for example, during the closing the space, is in relationship with the ligature. And it's very, very important, the bicycle brake effect, the contact between the ligature and the wire. You can see here the notching effect. This is the notching effect. You can see here in the notching effect here, the deformation, the bump of the wire, the deformation of the wires that produce a cold welding phenomenon. The bicycle brake effect, the contact between the ligature. You can see this picture from the electron microscope. I take this picture many years ago, and you can see the contact between the ligature and the wire and the bracket reduce the orthodontic tooth movement and produce the stop of the orthodontic tooth movement. For example, in many cases like this, with a conventional bracket in MEPT, for example, the conventional bracket with a conventional ligature, even with metallic ligature, reduce the orthodontic tooth movement and maybe more than 60%. If you apply 150 grams, for example, in these elastics, okay, the total amount of effective force in this tooth is less than 60 grams or 75 grams. And this is a huge problem because nowadays increase the friction of the surface of the friction of the new wires. For example, in the stainless steel is 100 grams, night eye or excuse me, is more than the double, and TMA is close to 4 times the friction of the stainless steel. For the reason I recommend to avoid the classical brackets at the start of the treatment. You try to align very fast the patient, and at the same time I recommend to avoid the classical bracket with elastic ligature when you are using a sliding mechanism in a case with maximum anchorage, in case when you need a retraction of the upper incisors. Okay, in relation with the slot design, no differences between the bracket and with even when you are using brackets like smart clip. In self-ligating brackets, don't work with the initial friction. Why? Because self-ligating brackets present the same slot, the same design that the conventional bracket. Okay, and the self-ligating brackets, especially the passive self-ligating brackets, present a huge problem at the end of the treatment because the lack of the torque, the lack of friction, and you need at the end of the treatment a lot of torque. For this reason, when you put conventional ligature, you have a problem with the friction, and the upper incisor present a big protrusion. Okay, this is the friction area when you are using conventional bracket and conventional night-tie wires, and this is the effect, the protrusion of the upper incisor and the lack of get down of the canine. At the beginning of the treatment and during the closing space phase, we have different types of friction. Now we have superelastic rectangular wires, but we can start the treatment with them. For this reason, the initial idea of our straight wire low friction technique that used the synergy bracket was many years ago to eliminate the ends of the slot of the conventional bracket. Because the initial friction is in relationship with the number of arch wires and the length of the treatment. When you try to introduce a rectangular superelastic wires in a conventional bracket, according with our researches in the University of Santiago de Compostela in Spain, you can see by means of finite element method the excessive movement of the root. The notching, okay, and we create the straight wire low friction thanks to the Rocky Mountain Orthodontic Company and comprehend the synergy bracket with the friction selection control, the friction tooth by tooth, and the shortening of the number of arch wires. High technology wires, superelasticity wires, thermal wires, 2 levels of force, beta 3 titanium, and gunmetal, and the use of the micro implants. We cut the end of the wires, and next we put in the middle of the wings a new wing. The synergy presents 3 wings. The wings in the middle is over elevate, and we create a third way between the conventional bracket and between the self-ligating bracket, active or passive. And this bracket is the synergy, and the philosophy is the straight wire low friction. And this is a present versatility, simplicity, and price. We start with the synergy many years ago and nowadays we have in the straight wire low friction. This is photos from many years ago in China, in Japan, in Korea, in Philippines, and now is a very popular technique in the world. The wings, the biconvex slot, and the number 3 is the rounded slot. The dynamic friction angle, this is a good idea because thanks to this dynamic friction angle is possible to diminishing the number of arch wires. Our second arch wire in 90% of the treatment, the second arch wire is the thermal wire 90 by 25 in 22 slot. Okay, for example, in this case, you can see the advantages of the scenery. You put the scenery and it's possible to bend a lot. 90 by 25 wire, thermal 90 by, it's not possible to do the same in a conventional bracket. And this is very important, the adaptation of the wire into the slot, and thanks to this. Another question in our technique is the value or the intrinsic value of the ligature. I agree with the idea of the self-ligating bracket that the ligature is in a step back in the history of orthodontic. It's not true. Ligature is a very important element, active element in the evolution of the case. For example, you can see here, when we put the ligature in a figure of 8, like here, like in this bracket, or here, we increase a lot the friction. And we are using this ligature to get a very good torque control. The opposite, when we ligate the scenery only engage only the central wing, you can see the elastic is not in contact with the wire, is because the design of the scenery produces an over elevation of the wings in this part, and the friction is close to 0, less than self-ligating bracket that I show you after. Okay, it's a very simple bracket, similar to a conventional bracket, and the most important is no caps, no problems, no break, no problem. And I think it's very interesting because it's like a similar bracket like MBT or another bracket, but the design is very nice. I start with the scenery many years ago in cases like this, huge crowding, a lot of problems with this canine, and the main problem with the conventional brackets at the start of my practice was the problem with the protrusion of the roots. For the reason in the MBT, in the technique MBT recommend to use the lace back ligature. If you are using the scenery, it's not necessary the lace back ligature because the special design of the slot of the bracket is in a good relationship with the rectangular super elastic wires, even with a thick like 90 by 25 wires. You can see the use of I start to use the scenery bracket in the canines and premolars, remain the conventional bracket in the upper incisor, like in this case, and the end of the treatment. And I like to show you the cases almost 5 years follow-up finish the treatment. You can see the patient, the follow-up of the patient, and step by step the use of the scenery bracket many years ago. The same in cases like this, with a very severe crowding, with a collapse, it's not possible to produce an overexpansion without obstructions. And in this case, I would like to show you the effectiveness of the scenery bracket and the conventional stainless steel wires, or with the scenery bracket, to put the lateral incisors in a correct position. You can see this lateral incisor is in a lingual position. In this patient, I remove the conventional bracket because I started treatment with conventional bracket. And now for finishing the case, I am using the scenery bracket. I use the scenery bracket, ligate the scenery bracket in a figure of 8. You can see here, and you can see how we move the root of the lateral incisor forward. The follow-up of the patient 5 years after retention, and the end of the follow-up of the patient. In many cases, very simple case. This is a very simple case. I use only one wire in the upper arch. We are using the Thermaloid 70 by 25. We start the treatment with this wire, 70 by 25 in the upper. Start with stripping between the upper incisor, control the papilla, and now I use the elastic change. I use the elastic change, and you can see control the space. We control, and the technique is a mix between the Roth, between Ricketts, between MBT, and between Damon. Okay, this is our philosophy of the treatment. It's a combination of 4 techniques with digital and virtual reality and the use of the neuromarketing to get new patients in our office. We use the friction selection control, different design, different slot. You can see in these photos with electron microscope the excellent adaptation of the 90 by 25 wires, supraelastic wires, to the inner part of the slot of the scenery. This is a very, very good and a nice picture to understand very well the advantages of the different. The control of the orthodontic tooth movement, tooth by tooth, only changing the ligature, and the possibility to diminishing the time of the treatment because thanks to the early and fast insertion of the 90 by 25 night-eye rectangular arch wires. For this reason, we ligate in the center for the minimum friction, maximum sliding in the beginning of each arch wire, medium friction control of the rotation in the conventional ligate of the scenery, and when we ligate in the figure of 8, we control the maximum friction, the control of the torque, and the control of the upper incisor. Like in this case, we ligate each tooth according with the control of the friction, according with the orthodontic tooth movement, and diminishing the advantages to introduce rectangular wires to diminishing the initial friction angle. What is the advantages? Okay, when we put the scenery, what is the big advantages? The big advantages is this. It's possible to move the wire backward. It's possible to move the wire backward. You can see this patient. We put the wires to align, okay? And now we put ligate in the canine and in the center to move the wire backward, okay? Okay. Remember this, when we need to move the lateral incisor forward very fast, I put an elastic ligature. This is the self-ligating effect. It's like a self-ligating brackets. Okay, and okay. At the end of the treatment, we need more control, and we control with the ligature and even with the metallic ligature. With a nice expansion, we combine a lot the scenery bracket with the Quachelis. I like very much the Quachelis and the philosophy of Ricketts with the utility, the combination between the utility and the Quachelis in mixed dentition. You can see the nice expansion. And this is the difference between the use of the conventional bracket with ligatures and the use of the super wires with the synergy. In this case, the night tie is a conventional night tie, maximum level of force at the level of the K9. And when we are using the synergy bracket and the special superelastic wires, pseudoelastic wires, the wire presents the same level of force in the different points. For this reason, it's completely different the one biomechanics with another biomechanics. The objective of the synergy is diminishing the number of extractions in our clinic due to the biomechanical mistakes. Okay, in many cases, the biomechanical mistake produce an increase of the orthodontic extractions in our office. For this reason, it's very important the control of the friction tooth by tooth, the power of the lips to control the protrusion of the upper incisor. It's very important that the lips to control the protrusion of the upper incisor and the sliding of the wire in the back. And you can see how we can control the root of the. At the end of the treatment, we are using now stainless steel, we are using rectangular Beta 3 titanium, and now it's time to increase the friction. We need a very good control of the friction of the K9, at the same time a very good control of the friction of the upper and the lower incisors, especially the upper incisors in K9. For the reason, ligate the upper K9 and the incisor in a figure of 8 to increase the value from 0, close to 0, is the friction when we are using only ligatures in the middle of the bracket, increase a lot when we are talking about the friction in the upper incisors. And in this case, it's close to 200 grams. Okay, and okay, this is a patient many years ago, crowding, very simple case. The first step, distalize with a pendulum the molars. The first step to control the molars and to put the upper molar to change from the class 2 to close to class 3. Now, what is the most important after to put the molar in class 1? The most important is to retract the premolars and the K9. For the reason, ligate the premolars in the middle to diminishing the friction and to move a lot very fast and very backward. The intermaxillary elastics, the end of the treatment, and the patient years later. Remember, when we are seeing patient 5 or 10 years after orthodontic treatment, remember that the main problem in our patient, almost in my office, the main problem is the gingival recession. The gingival recession for brushing, but in many cases is a problem for the overexpansion of the overexpansion. We have a little bit overexpansion of the patient, overexpansion of the arches, and I think it's very important to control this. Okay, the patient after the treatment, and it's very important the connection between the synergy and the super elastic wires, the pseudo elastic wires is very important because the super elastic wires producing the lateral incisor, the K9 and the first premolar the same increase the deflection but produce the same force. This is a very good success, and when the people from Damon talk about, oh, Damon bracket is the most important in the technique, is not true. The most important in the technique of Damon, in the technique of Carrier, or in the technique of strival flexion is the possibility to increase to stimulate the alveolar bone growth thanks to the use of the night tie super elastic wires. Okay, it's possible to use the braided night eye braided to align to very fast to align the teeth in cases of extractions. Okay, okay, and okay. Even when we have a patient ITs with a lack of cooperation with headgear to installation the upper molar, it's possible to do a very effective distalization, very simple, 90 by 25 stainless steel, night eye coil spring, a crimpable hook. I put the crimpable hook in the reverse way, instead in the and class 2 elastic. It's like a Luis Carrier appliance. It's like the idea is to distalize a lot the molar first, and second engage the canine, put elastic in the canine, and finish the treatment only with very simple and very cheap appliances. I start to use the scenery close about 2002. This is a patient I treated with scenery bracket many years ago in 2002. We combined the super elastic wires. In that time, I didn't use the Rocky Mountain wires. I used the GAC company because GAC always has a very spectacular super elastic wires. The different type of centalloy, the neo-centalloy, the spectacular wires, and I like very much. In this case, you can see it's a patient. We use the stripping, a lot of stripping, put the canine in class 1, and the most important is the effectiveness of the scenery bracket to control the position of the lateral incisor and to move forward the upper roots. 2010 and 2014. You can see the stability of the results with scenery, the good results with, in a case with a very huge crowding without obstructions and without problems in the future. Another problem is a patient with crowding, severe crowding, and the main problem of this patient, the patient lose the first upper molar before the treatment. What is the normal plan of treatment in my office many years ago? But this case is the extraction of 3 premolars. 1 premolar in the other side in the upper and 2 premolars in down. In this case, start the treatment with a round superelastic wire. Produce expansion. I use a little bit in many cases in night eye wires, bend the wires a lot here and here to increase the expansion of the premolars and the expansion of the molars. Now we are using beta 3 titanium in the upper and braided stainless steel in the lower. I like very much the braiding stainless steel when we need to engage. For example, in the middle of the treatment, I have a problem with the engage of the occlusion. Open the bite, maybe open the bite in the posterior area. In this case, I put a bite block in the blue bite block in the posterior, and I like very much when I try to engage with short and heavy intermaxillary elastics. And we are using this. Now it's time to close in the space. The biomechanic to close in the space in our technique is very similar to MBT or another technique. I don't like the biomechanics with the WK Hoy loop stainless steel wires. I hate this type of closing space because you lose a lot of anchorage and obligate to do a lot of extractions in your office. The best is this. The first step is to put as soon as possible the canine in class 1, engage in class 1. Next step is to open the space between the canine and the lateral incisor. Here it's possible to put a crimpable hook or in many cases a loop, a preformed loop, or make the loop with the pliers. And in the crimpable hook, put an elastic change or a coil spring or something like this, put the canine in and finish the case. We are using now, very important, we need a lot of friction in the upper incisor. For this reason, ligate the upper incisor in a figure of 8. And in the canine and premolars, we need the opposite. We need low friction because we need sliding. We need the sliding of the bracket around the wire. For this reason, ligate in the center. Okay, and the follow up with the middle and the aesthetic of the patient with a very good aesthetic without extraction and with a very good stability of the patient. Synergy is not a very popular bracket, but you will surprise because we have a lot of scientific evidence based biomechanic about it. This is a famous article in 2007 about the advantages of the Synergy bracket in relationship with the Damon bracket or with the Smart Clip. And this is from Carla Evans from the University of Chicago and from Qin Liang Yen from Taipei. Okay, you can see the difference between one bracket and the other bracket, the Synergy bracket. Another very interesting article, 2013, in the prestigious journal, a Scientific World Journal, 2013, from Dr. Perillo from Italy, and demonstrate and show the advantages of the Synergy respect to the low friction and the diminishing of the friction in the different situations. The synergy with silicone ligature, the special ligature to diminishing more the friction, present the lowest friction values at all degrees of malalignment tested in this study. The same Professor Cordasco, in a very good study in Progress in Orthodontic in 2013, compared the Damon 2 with the Smart Clip, with innovation and synergy. And synergy present less friction. When you ligate the friction, the synergy with the silicone in the middle, that Damon or in ovation bracket. 2015, American Journal of Orthodontic Dentofacial Orthopedic. The same. In this article, you can read the advantages of the synergy from Rocky Mountain and at the same time, synergy and time 3 from the American Orthodontic present the less values of friction. And synergy, according with the author, take a lot of advantages of the special design of the slot for the control tooth by tooth of the orthodontic tooth movement. Journal of Orofacial Orthopedic 2019, the same, the advantages of the synergy respect another more expensive brackets, more sophisticated brackets, more self-ligating brackets. The advantages of the synergy, and I think it's very interesting, this last article. It's very important to understand that the night eye, pseudoelastic night eye, will take another advantages and to avoid the hyalinization and the necrosis of the periodontal ligament. It's very important the economy of your office and the synergy bracket and the synergy bracket and the technique, the global technique of straight wire is the Damon bracket and the technique of Damon, for example, is 2, 4, or close to 5 times the price of our philosophy. The digital orthodontic multi-technique comprehend the combination between the synergy bracket, the metallic bracket, and static bracket, with the mini implants, with the mini implant. We use the mini implants, for example, to control the occlusal plane in patients with, to control the gingival smile, to treat open bites. This patient with an open bite, I put a couple of mini screws to close the space, to use the mini screws in combination with brackets and wires to treat the canine included in the palate. And now with OrthoPlus, with a Spanish company in the south of Spain, with company OrthoPlus, we are working in striate friction digital. We are working in the indirect bonding. We are using the indirect bonding for the bonding of the synergy bracket. Okay. And I think it's very important also the automatic selection of arch wires. It's possible in the computer to the selection of arch wires according with different criteria. For this reason, we use the wires. Okay, the first arch wire in this patient is 18 90, and the next arch wire is 90 by 25 arch wire. You can see the dramatic change and the very, very good change of the premolar, the rotation, the position of the molars, only using a couple of arch wires. In our technique, we are using we divide the technique in 4 steps: alignment, leveling, closing space, and finishing. And I think it's very important to connect the 4 phases of our treatment. For the alignment, we use the thermal 16 for the high irregularity index, 18 for the medium irregularity index, and 90 by 25 for patient with low irregularity index. For leveling, we use leveling and finishing. We are using beta 3 titanium, and for closing space, we use beta 3 titanium or true chrome stainless steel. Okay, this is very important. In our office, in 90% of the cases, when we start the treatment with all teeth, in 6 weeks, the patient present 90 by 25, or we put 90 by 25 in the mouth of the patient. 90 by 25 thermal wire, super elastic thermal wire. Another possibility is to use gunmetal. We use the gunmetal for leveling and finishing. Okay, gunmetal is a special alloy for this type of treatment. And nowadays, remember the evolution of the super wires. Now we have night copper, we have super elastic austenitic night, and wires like the gunmetal. I use it a lot, the gunmetal. What is the gunmetal? It's a dream of angle. The dream of angle, only the use of one arch for all the treatment. Is possible to do all treatment with one wire alloy? Yes, thanks to the gunmetal. The gunmetal presents a lot of advantages. It's possible with a very spectacular behavior, biomechanical behavior, present a lot of very good properties to work in the mouth without only with one wire for alignment. For example, another advantages of the synergy bracket is this. For example, we ligate the upper canine, the right canine, with a metallic ligature to strengthening this tooth. At the same time, ligate the rest of the teeth in the center, the premolars, lateral incisors, and the center, and you can see the maximum effect of the appliance at the level of the canine and the minimum effect in the rest of the teeth. This is the gunmetal composition. The advantages: the non-linear elastic behavior is super elastic, the spectacular active torque with gunmetal, and we are using the gunmetal for closing a space, and also I use a lot the gunmetal for closing the bite for the open bite cases. In cases like this with an open bite, we use the upper curve of speed and the lower curve of speed. In my opinion, it's not necessary to do a lot of loops like a king technique. It's enough with to put the gunmetal in the upper and in the lower, and maybe to do a loop or simple loop to close the bite only with this type of biomechanics. Put the elastics in the upper and reproduce in the lower. It's the same in patient with like this, with an open bite. Okay, put the elastic on the gunmetal, and you can see to activate the gunmetal into the mouth to close the bite. For the reason we use different possibilities, but one possibility is this, is to start the treatment with gunmetal or maybe with a thermal oil, the force wires, and to finish the treatment with gunmetal. We use the gunmetal during the leveling with a curve of speed, bending the wires, closing the space with the loop, and finishing with a step. Okay, and I remember realized that the students love the kitchen and love the orthodontic recipes. And for this reason, it's very important to understand, okay, this is a joke, this is understand the property of the different wires. We have a lot of wires, a lot of alloys, a lot of different systems, and it's very important to know the evolution of this type of wires. In 1982, I last for the alignment and to get to 90 by 25 still to the working arch, maybe we need 1 year. 1 year. Today, to get to the working arch wire in stainless steel 90 by 25 or 90 by 25 TMA is enough with 4 or 3 months. I think it's completely different. It's the same like the car in 1982 and the same model but different car in 2016. For this reason, during the alignment, the main advantages of the synergy respect the low friction bracket, the self-ligating bracket, the conventional bracket is to start with 16 or 18 thermal even gunmetal, and in 6 weeks, only in 6 weeks, to get a 90 by 25 thermal night eye. Okay, the big advantages is the superelasticity. The big advantages is the use of this type of wire. This is a thermal oil. Remember, we have two presentations or two types of thermal oil in the same size. This is the conventional and the plus. The plus produces W of force. For this reason is the different than a conventional nitinol. Remember this nitinol in 2000, and nowadays it's possible to use the new nitinol plus or nitinol conventional to get the lateral incisors in this situation to forward as soon as possible. Remember this, the same force. The advantages of this wire is they produce the same force independent of the deflection of the wires. For this reason, we have to coordinate this. For the alignment, what is the advantages? What is the objective? Crown alignment, no rotation, anatomical points. For leveling, deep bite, the curve of speed. For closing space, with the objective is no diastemas, root parallelization, and for finishing the control of the torque, the dynamic occlusion, and the detailing. For this reason, we are using superelastic wires, thermoelastic wires, differential flexibility for leveling, for closing space, vertical control and stiffness, and for finishing stiffness and AC to bend in the mouth. Remember, for the alignment, we use flexibility, avoid delay of hook, sliding, and for finishing, stiffness, 3D control, detailing, and friction. We use the irregularity index and discrepancy for alignment, deep bite and curve of spin for leveling, the criteria to select how to close in the space is the anchorage, the percentage of distractions in our office, where close the space, and the biomechanics. And in the fourth, the need of torque, the static and occlusion and the dynamic occlusion, according with the coordination between the maximum intercuspidation and the central relationship. The different types of wires, we are using the thermal wires, beta 3 titanium or TMA wires, stainless steel wires, and different types of wires. We use also the night-type copper to produce overexpansion in cases with a patient with a very severe collapse. I like very much the bypass arch wires with LG for the beta 3 the utility arch or mulligan arch wire, and for the beta 3 titanium we use the braided stainless steel. For the alignment, very important, the crown alignment, no rotation, and the regularity index is close to 0 millimeters. This is a patient with a severe crowding. In this patient, this is a patient with a severe crowding. The extraction of this patient or the treatment of this patient with extraction is a little bit difficult because the patient presents to the shift to the upper midline to the right and the shift to the lower midline to the left. In this case, if we decide to extract, we have to extract first in this part, in the upper, we have to start first the first premolar in the upper. Next, we have to start the other. In the lower, the first is this, and the opposite is in the lower, is this. For this reason, it's very difficult to understand the situation, and you can see the crowding. Start the treatment with the super elastic wires, now the thermal wires, and now it's time to use the beta 3 titanium. Bending the wire, okay, bending the wire in this part for the extrusion of the canine, for adjust the proper situation of the lateral incisor, ligate the upper in teeth with a ligature, and the elastic to engage the occlusion. Okay, and the end of the patient, and you can see the patient years after the treatment. In many cases, it's very difficult, the evolution between the extraction and the expansion. I talk about this in the first webinar about the extraction can be a reason to change the orthodontist. In cases like this, patient with severe crowding, we start the treatment with and inform about the risk to treat this patient without extractions. The start of the treatment is using utility to move the lateral incisor forward, distillation the upper molars, and now we are using heavy and short elastic to close the bite in the front. Okay, and the end of the treatment, you can see the stripping here and the stripping here. Okay, and okay. It's important to remember this, and remember this is important to remember the overexpansion. Remember the overexpansion. In many cases, patients like this with a very severe crowding, with the protrusion of the upper and the lower, the advantages of this patient is possible to move forward the lower incisor. It's possible to move forward the lower incisor. We analyze first the natural head position of the patient. We draw the true vertical through the nasum, the nasolabial angle, analyze the distance to the true vertical to the A point, to the maxillary, and analyze the overjet and overbite, and analyze the position of the lower incisor in relationship with the functional occlusal plane. The upper incisor in relationship with the true vertical, 4 millimeters. The inclination of the upper incisor in relationship with the true horizontal, with the Frankfurt plane is about 130 degrees. I think it's very interesting, this measurement, to control the position of the upper incisor in relationship with the Frankfurt or with the true horizontal, the lower lip, the interincisal angle, and a lot of measurement. Okay, what is the advantages of this patient? It's possible to move forward the upper and the lower incisor, expand the patient, expand the protrusion of this case, and now I put wires in the upper and the lower and open the space between the premolar and the central incisor. Now we have to engage the elastics in this position, okay? And now we are using the very short and heavy elastic to engage in the occlusion. Okay, the result of the treatment was very nice. The patient is very happy. The occlusion is okay. The X-ray is okay. Okay, and you can see the superposition of the end of the treatment to our VTO, our objective visual of treatment. Okay, and you can see the patient, okay, years after treatment, not a lot, maybe 4 years, 5 years after treatment. Please, the patient is very happy, but I am not very happy. This is a complete disaster. This is a patient of my office. This is a complete disaster. This is a complete disaster. What was the problem? Please remember to the people like Damon, overexpansion. Overexpansion produces a lot of problems in the long term. In the short term, every patient is very happy. In the long term, you can see the result of this problem. It's very difficult to do a prediction about the gingival recession. Maybe the problem with the brushing of the teeth, but the main problem of this patient, remember, is a severe recession. Severe recession for the overexpansion. Be careful with the bone loss gingival recession, and remember that after the party of the expansion comes the hangover of the relapse and the recession. Remember this about the orthodontic tooth movement, about the different biomechanics of the cells, about the orthodontic tooth movement and the biology of the events in the periodontal ligament after the application of our brackets and wires. The relationship between the osteoclast and the osteoblast and the change of 5 microenvironments: the extracellular matrix, the cell membrane, the cytoskeleton, and the genome. For this reason, remember this, we have a lot of journals, a lot of articles in different journals about the prevention of the radicular resorption, the prevention of the gingival recession, the prevention of the problems when you try to move the teeth with. For this reason, the role, for example, of the nitric oxide is very important in orthodontic is the Viagra for the orthodontist, because it's a relationship between the vascularization and the activity of the osteoblast and the fibroblast. Okay, the role of the osteoclast. And remember, when we use light force, we have a direct resorption, direct bone resorption. When you increase the heavy forces and you increase the stop the orthodontic tooth movement, producing ealinization and necrosis. Really, it's not an ealinization, it's a necrosis around of the periodontal ligament. And this is produce a poor of cellularity. For this reason, the role of the osteoclast, the role of the rank, and the role of all of these enzymes and elements is very important. Refuse the use of heavy forces. Refuse the contact between the root and the cortical bone. Refuse the jiggling orthodontic movement. For this reason, remember to Thailander, Perrite, or Radian, talking about the hyalinization, necrosis, and radicular resorption. We have to avoid this part of the orthodontic movement. For this reason, it's very important, this is idea, to use what? To avoid the hyalinization, is very important to avoid the intensive forces. The use of the super elastic wires, they refuse the use of the classical nitinol or nitai poor quality wires. Remember this, and this is very important. Then another problem during the alignment is the dental eruption and the attached gingiva. Very important to control the periodontal problem in the patient. This is a patient with a very severe problem with eruption, because the eruption of the upper incisor and the lateral incisor is in a free mucosa, it's not an attached gingiva. And in this case, it's very, very, very important to use light forces to avoid the protrusion of the incisor, to control the rotation of the upper incisor. We are using round superelastic wires, excuse me for the highness of the patient, and we use the elastic to engage the upper and the lower. And now we are using stainless steel, very important stainless steel, for the control of the torque of the patient and the end of the treatment. Very important is the stripping. I like very much the stripping to get a very good surface of contact between the upper incisor for the stability, and even for the, and you can see the patient years after the treatment. Okay, for this reason, it's very important the control of the stability of this patient. The rapid accelerated phenomenon, or another type of microsurgery, like a hole to put holes, or accelerant, or aerodentist, or another type of new device for stimulate the orthodontic tooth movement, is not very, very, very practical in contemporary orthodontic. Please remember this. This is a patient with a severe crowding in the upper and in the lower, and I decide to treat this patient fortunately with extractions. You can see the patient after the treatment, 2 years maybe after the treatment, and you can see the patient, the same patient, 6 years after the treatment. The follow-up of the patient. Please check the problem of this patient. Check the gingival recession in the premolar area and the gingiva, even after finish the treatment. For this reason, it's very important, and remember the long-term health periodontal health of this patient. Another question about the use of the first phase of the treatment is the smile design in orthodontic. Who is the expert of the smile design in orthodontic? For example, we are talking about how to treat the black corridors. It's possible to avoid the use of, or to treat the black corridors or to avoid the black corridors. You have to change the natural teeth and to change your artificial teeth to expand on the posterior teeth. You need to change the alveolar bone or to expand the maxillary with rapid maxillary expansion to expand the basal bone, or to change the thumb corridor muscle, or in this case the GP or the cosmetic dentistry or the prosthetic dentistry only is possible with this. The GP is possible to change the natural teeth in artificial teeth, to change the alveolar bone, to change the basal bone, or to change the thumb corridor. Is very important to understand this. This is an orthodontist. Orthodontist is the expert in digital design smile. This is a patient, for example, this is a very common case, very simple case. The idea of this patient is we have to treat the black corridors. To treat the black corridors, the first idea is to reduce expansion. In this case, it's a very simple dental expansion. We use a simple dental expansion, only expansion the maxillary, only expansion the maxillary, okay, with a Coagelis and very simple treatment, only Coagelis to produce a protrusion of the lateral incisors in the canine, okay, and this is the end of the first phase of the treatment. In the next stage of the second phase of the treatment, very simple, we use the round 18 Mulligan arch wire. The next is the use with the beta 3 titanium, in this case gunmetal or beta 3 titanium, to make a loop to the control of the upper incisor. The loop is to the vertical control of the upper incisor to control the gingival display, stripping the palatal bar in the upper, okay, and the end of the treatment. This is a very simple treatment, but you can see the effect of the very simple treatment in the smile design of this patient. For the reason the orthodontist is the most important element in the smile design of the patient. Thanks to the orthodontist, it's possible to expand the arches, and you can see the patient years after the treatment. Okay. In other cases, we expand the arches during it's not the alignment, it's the span the arches, thanks to the use of the rapid maxillary expansion, in this case, in the early treatment. This is the first step. Another patient with a severe collapse in the upper and in the lower, the class 3 malocclusion. Okay. Now the idea is to analyze what is the problem of the patient. The patient is analyzes the peripheric comparator according with Petrovic. Is possible the contact in the canine, the contact in the premolars produce the forward functional movement of the muscle, of the mandible, and the muscle produce a change at the level of the central nervous system. Change the TMG, the hormones, and the growth is possible to change and the dentoalveolar compensation. Okay, it's very important the control of the anterior guy, Very important, the control of the growth and the control of the condyle, the dental-alveolar growth, and dental or skeletal, squamous or rapid maxillary expansion. We analyze the differential width, the inclination, the torque, the curve of Monson and Wilson, and remember, in case of that, always skeletal rapid maxillary expansion. For this reason, in this case, we decide to produce a severe expansion of the maxillary. You can see the expansion of the maxillary in this patient, okay? And the end of the treatment of the first phase of this patient, okay? The end of the first phase of this patient, and you can see the dramatic change of the face thanks to the use of the facial mask and the rapid maxillary expansion. In other cases, we need extraction, we need expansion, like in this case, open the space for the lateral incisor, move forward. We are using intermaxillary elastic to avoid the open divide, and now we are using the ligature in a figure of 8 to control the torque in the upper and the lateral incisor. You can see the expansion and the nice expansion and the patient years after the treatment. You can see the profile of the patient, the nice smile of the patient, and in other cases, during the expansion, during the alignment, during the first phase of the treatment, we need to change the environment, to change the equilibrium between the muscles of the thumb corridor. For this reason, it's very important to understand that the malocclusion is the product of the etiological problem of the malocclusion depends of the genetic and the epigenetical problem. The epigenetic is in relationship with the muscle, with the teeth, and the alveolar bone. Okay, for this reason, we have to treat the muscle, we have to treat the teeth, we have to treat the alveolar bone. This is a patient with a collapse of the maxillary, a collapse of the teeth, and the face of the patient is okay. The white of the patient is okay, the face. And what is the problem of this patient? The problem of this patient is the muscle. Present a hyperactivity of the upper lip muscle, of the orbicularis muscle, present an hyperactivity of the upper part of the buccinator muscle and the modiolus. And for this reason, what is our plan of treatment? The control of the muscle. I start the treatment with a quachelis to expand the molars, even to expand this premolar, but at the same time, I like very much in this patient to combine the expansion of the quachelis with a functional appliance, a very simple functional appliance to use only during the night and maybe at home. The role of these lip pads is maintain the muscle apart and to produce the best place to the eruption of premolars and the molars. After the use of this appliance, you can see a very nice eruption of the premolars. Now it's time to use the strival flexion, diminishing the number of arch wires. The first arch wire is a round wire with a lot of expansion. In this case, it's very good, the night-type copper. The next arch wire is a 90 by 25 thermal wire, and now it's time to control the torque. We are using the expansion of the arch wire to have a very nice smile in this patient, but remember, we need negative torque at the level of the molars and the premolars to get a good occlusion. Expansion of the wire for the aesthetic and negative torque of the premolars for the occlusion. For this reason, it's very important to get down the vestibular cuspid, to move to the negative torque to the root of the premolars, we are using the negative torque and we are using the intermaxillary elastics. The end of the treatment, you can see the nice expansion. The straightening is not expansion, it's straightening. It's not expansion, it's straightening of the premolars and molars in the lower and in the upper. Change the inclination of the crowns and the smile of the patient. For this reason, it's very important, like in this patient with an asymmetrical mandible, the same, the peripheric comparator of this patient, the same. What is the problem of this patient? The main problem is the shift of the TMG in the right and in the left. Okay, for the maxillary expansion, dental skeletal or skeletal. In this case, at the start of the treatment, it's possible to produce the expansion only with a removal appliance. We are using a removal appliance with a screw to produce the protrusion and the lateral incisor. Okay, and we move the screw every 2 or 4 months. Very simple treatment, expansion, very simple treatment and expansion, and at the end of the first phase of the treatment. The end of the first phase of the treatment, now it's in the rest period, and in the rest period you can see the lack of space for the canine and the premolars. Okay, now I decide to extract the second molar, and put a little button in the lower to retract the second premolars and to regain space in the freeway space. Okay, now it's time to put the crimpable hook in the upper and crimpable hook in the lower, engage with the intermaxillary elastics. Very important to organize the biomechanics of the strike-whirl of friction tooth by tooth to control the torque. Now we are using beta 3 titanium. In the upper arch, we ligate in the figure of A for the maximum control of the torque. Okay, for the maximum control of the torque, and in the premolar here you can see the bending the wire. Okay, for the engage. The end of the treatment, and the end of the treatment, and the follow-up of the patient. Finishing the treatment. Okay, this is the second webinar. Thank you very much. Okay, thank you very much for your attention, and we are going the next time to talk about the advantages of the use of the strike-whirl of friction with the thermal wires, with the night-tie wires, with the use of the super-elastic wires, and also we are going to talk about the advantages to use the different biomechanics to treat deep bite problems and open bite problems. We are with the use of by means using curve of speed, use the utility arch, use the mulligan arch. We are talking about the biomechanics. Thank you very much. Thank you very much, and good night.